Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very pleased today to be talking with Dr. Art Kaufman, a family physician. He's a distinguished professor of family and community medicine and vice chancellor for community health at the University of New Mexico. Art, it's very good to have you with us, and I'm going to turn things over to you with just sort of the lead-off question. Our goal in this session is to share with people what you and your colleagues are doing to address the primary care workforce issue. And you've got some very interesting programming, and I'd like you to share that with the people. And if I need to, I'll jump in and ask some questions, but otherwise you're on your own.
Thank you very much, Larry. So this is a real passion of mine and our whole program, both the department, but also our Office for Community Health. And I'd like to start just with a data fragment, which is really meaningful. And that is, we understand that quality care is just not enough. And we're using deaths from diabetes as an example among our Native American population, which is a significant minority in New Mexico. And if you look at the one population that has the highest rates of screening and best interventions for diabetes, it's really the Native American population because of federal and state programs, the Indian Health Service and others, yet they have the highest rate of deaths from diabetes. Best quality care, worst outcomes. And the reason isn't because of the quality of care, it's because that quality can't make up for decades of high unemployment, poor educational outcome, poor nutrition, housing, transportation problems, all of the social determinants that have a much higher impact on health than the way we are trained as physicians. And if you look at New Mexico, you'll see that the Institute for Public Health ranked every single state. And if you're at the bottom, it means you have the highest rate of adverse social determinants. And that's why we cannot make much impact on health of our population and even of our individual patients unless we are addressing social determinants. The health workforce is a social determinant also because it has a big impact economically. And if you look at the rate of primary care physicians per 100,000 population, each doc in a rural area hires about 18 people directly and indirectly, generates $1 million in business every year. That raises the tax base of those communities. And it could be that the economic impact of primary care has as much, if not more, to do with health than direct services themselves. But more recently, we're learning more and more about the lack of ethnic diversity on our healthcare workforce. So that, for example, if you look at the rates of African American, Native American, Hispanic physicians treating populations, they see about 5 times as many patients of that ethnicity as the Anglo population. If you think of our state, or no, just our state, our nation, within about 30 years, the majority of the population is going to be, quote, ethnic minority. So the access is going to be very poor. The other problem is the economic disparity, which we don't talk about enough in the United States, between physicians and their patients. Our patients are not rising rapidly in terms of economic improvement. The highest 1%, yes, in the population, but not the general population. And yet the physicians, the families from which those medical students come, they keep going up, 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 and they're in the highest rung of income. So there's a real concern about the disparity between economic background of physicians and the patients we expect them to see. Now, New Mexico is a rural state. And we have to be very mindful of where the biggest deficits and biggest disparities are occurring, which is in rural New Mexico. And we found that if you look at all of our data and our research, the more likelihood of a doc going and working in rural New Mexico is they have to come from New Mexico, from a rural area in the state. They are from an underrepresented minority. They do their medical school and residency and family medicine in New Mexico. Those are all the factors. But just look at these top factors. How likely is it that a kid from a poor background, their first language is either Native American or Spanish, to do well enough in high school to compete with someone who's upper middle class in a private school in an urban area? You have to change the whole nature of how you're accepting people and what you assume is your real goal. And one of the great things that our medical school did was they changed the nature of admissions. They changed who's on the admissions committee to reflect the state. But they also took a quarter of all medical students come from rural and ethnic minority communities. And that's a risk, because even though they may be the top of their class in a very small town, they don't necessarily compete well in the early competitive standardized tests. So it's harder, but they get through. When they get through, they're as good as anyone else. And what was interesting in this program is half of these graduates over the years have gone into family medicine. Again, the link between where you come from and going into primary care, and particularly into family medicine. So it has changed the nature of the ethnicity of our medical school, which looks more and more like our state, and where they choose their specialty. And it was 2 years ago, we actually were the highest percentage in the country of medical students producing family physicians. Not numbered because we're a small medical school, but in terms of percentage. Now, we have to be realistic about who we're training for primary care. Very few internal medicine are going into primary care now. Many people have a hard time distinguishing hospitalists from internal medicine primary care. If you add those, we're really small percentages. And this is true of New Mexico as well, where maybe half at best of pediatrics is going into primary care, PAs less, NPs at best 50%. So we're really left with family medicine being the bulk of primary care physicians, but they can't make up quickly enough what the deficit in internal medicine and pediatrics is. We're very much helped by PAs and nurse practitioners, not enough, but there's a movement in that direction. So all of our data showed that if you could train residents, in this case, family medicine in rural New Mexico or smaller towns in New Mexico, you would get a much better outcome of graduates staying in rural New Mexico. And this is the data. We have a fairly large network of family medicine residencies, and actually this year we're growing even further. But of the 76 residents that we train, about 25% of the Albuquerque graduates are working in rural New Mexico, but 70% of those in rural communities are working. So our whole push now is to expand the rural or smaller community sites. One of the mechanisms for paying for this is state Medicaid, which is critically important because up until recently, state Medicaid dollars just followed the Medicare dollars. And those Medicare dollars really followed the whims of specialists in the hospitals. They take care of the teaching hospital needs, not the community needs. And so the state got wind of this and they said, our Medicaid dollars don't have to follow that. We would like to reallocate, or at least if we can get an expansion, put those into where we really need it, which is primarily family medicine and psychiatry. That's where the really bulk of the need is. And now, sadly, and it's just interesting, the Primary Care Association of all the FQHCs did not like this idea. They wanted all FQHCs to get their funds increased, and this looked like if they got residencies, they would get a big increase. So instead of saying, no, those are the ones that are spending extra time on residencies. So what happened is, rather than having that fight, some FQHCs would continue with their residencies, but the big expansion are going to be in community hospitals. And that's what we've done. It looks something like this. We developed a 10-year plan. We said, look, we need to get so many more, and this is a couple of years ago. We need 200 more primary care docs. in New Mexico. If you said half of those would be internal medicine, pediatrics, nurse practitioner, physician assistants, then we need 100 coming out of our residences. So and this is the list of how many residents per year we're now training above and beyond what we had before to get to that, an extra 14, to get to that 100 extra slots. So it's being intentional and starting with what does the community need, not what the teaching hospital needs. Now, this is the next part of this, which really rocked our socks. As we started to work more in communities, we had developed our Office for Community Health, and we spent about 6 months asking communities, how are we doing? How is the University Health Science Center helping your community? And it wasn't pretty. They said, you're known as the University of Albuquerque, not the University of New Mexico. You only come when you get a grant, you disappear when the grant goes away. You build on what you want. You don't ask our wisdom and our organizations. You're really not committing to us long-term, just short-term stuff. And by the way, you don't compare well to the Agricultural College, New Mexico State University, which has its agents in all of our counties. So we said, wait a minute. We play New Mexico State in basketball and football. What the hell are they? Why does everyone love them and not us? So we had to learn a lot about health extension, agricultural cooperative extension. And it really took us by surprise. We learned all about it. New Mexico State was very generous. They brought all of us down for a day of Cooperative Extension 101. They gave us, packets to study. But what we learned is this goes back to the time of Lincoln, where the government at the time in the 1800s was very concerned that farmers didn't get the best science out of their local colleges. So they made sure that every state had an agricultural college that would teach the best science, increasing crop yields, helping safe canning, helping kids get through school, 4-H clubs, how to be successful farmers. But that has grown. So every single county in the United States has ag agencies. Some have offices of agriculture with cooperative extension. So we wanted to model ourselves after that and become liked, just like they're liked. And so we went about putting these health extension agents in different parts of the state. We have about 10, 14 of them now. And what was interesting, and this gets back now to primary care. As it turns out, we found that you don't have to have a full 3-year residency or a 1+2 residency in a rural area. If you have a robust training program where residents from any of these programs cycle through those communities, they are very attractive to graduates because they live in them for some months at a time. And so let's go way down to the lower right, hops. Most difficult place to recruit. It's an oil patch. I mean, it's ugly. It's got pump jacks. It smells of gasoline. And it was very hard to recruit. And they set up a welcoming kind of program where we sent residents from all of our programs to Rotary a month at a time. And they gave free housing and food. The community was so welcoming that their deficit in 29 primary care doctors dropped to 9 after this decade of rotating through. Santa Rosa, absolutely the same. They actually gave us money for full-time resident position. So we always have residents. It is the best frontier experience our residents have. All of their doctors are from our program. Zuni, the same. So there's a connection between health extension and training. And that's really important to us. So our plan currently is let's go whole hog. We'll be like agriculture. And we'll put health extension agents or heroes in every county and in the 6 major tribal communities in the state. So that's our next step. This was very popular as an idea. And we wrote Section 5405 in the Affordable Care Act, which is how do you have health extension help primary care. Now, the next portion of this has to do with the environment in which primary care works. And that's really important to us because if there's too much stress and burnout, it doesn't become very attractive. So this Robert Wood Johnson survey showed 80% of docs, mostly primary care, felt that social determinants were important, but and were as important as medical problems, but they had no means to do anything about it. The health systems in which they worked didn't help them. And by the way, it's not just poor people, it's everybody. So we put together a social determinants prescription pattern. And we asked all the patients that came through primary care at the university and our partner, federally qualified health center, we asked these questions. And lo and behold, half the patients, these are now 50,000 we tested, these are just the first 3,000, 50,000 are the same. Half the patients had at least one adverse social determinant, and half of those had more than one, and some had 5 or 6. But we didn't know about that because these are not the questions we usually ask. So for example, I have every patient, every adult comes in and I get a respiratory rate. I can't remember using that in the last 45 years. But this data I don't get, and it would make a huge impact on how I care for my patients. So we then hired community health workers and trained them in all of our clinics. And they are by far the most popular new addition to family medicine and primary care because they take things off our plate. Can you believe that? They're the first people to take things off our plate. The most complicated, they take care of it. Need more money? We'll figure out how to. I'm going to take you to the income support division. I'm going to make sure you're not evicted. I'm going to make sure your car is not repossessed. They do. I don't know how. I didn't even ask them. I don't know how they do it. They do this work, which is extraordinary. Well, as it turns out, we've built this program that has a very high return on investment, and the state Medicaid now has bought into this, so they require every managed care organization that they fund has to put a substantial amount of money into hiring community health workers, and it's all over the state. Our next, this past year, the past 2 years, our next approach was, our clinics now have community health workers in, but I'm sure your clinics are the same around the country. They're filled with medical assistants. But I didn't know much about them. I worked with them, but I didn't understand their background. Yet medical assistants and community health workers reflect the ethnicity, the linguistic ability of our communities served. They live in those communities, both of them. The difference is that they get paid much less than community health workers. We start community health workers at $17 an hour. They are paid a beginning wage, let's see, their hourly is $13.50 an hour. Yet they have very high debt. The reason is they train through these private colleges, which give them a certificate after a 10 or 12-month training. And those certificates cost $15,000 to $18,000. The training private college gets all their money from the feds up front, but then the MA has to pay back over huge amounts of time. So we said, we have to stop this. So we are training them for nothing. And at most, maybe $3,000 by partnering with a local community college. So you now have primary care physicians, community health workers in the clinic, and now medical assistants that we're training up to be part of this team because they ask all the social determinants questions and then they hand off to the community health workers in our clinics. This saves huge amounts of time for the family docs and the residents. So I just want to end with this. There's one more after this, but with this issue. If you look at who stays, in this case in rural New Mexico, but it could be in an underserved area, physicians are hardest to retain, mostly because of who we get into medical school how we train them, their comfort with lots of technology that may not be available in that area. Nurses, you can retain better. But medical assistants, community health workers are there. They stay. They're from those communities. Their families are there. And I think primary care and family medicine in particular should be advocates of figuring out how to train up those who are in the communities to stay, rather than only putting effort into recruiting and retention, which sometimes is quite hard. The last slide I want to give before we get into a discussion is this. In order to make money, all of these social interventions can become popular with managed care, with hospitals, if you focus just on the top hotspotters, the high-cost individuals. But remember back that slide that showed half of our patients have an adverse social determinant that's really not known. So in order to make an intervention, you have to go deep, way deep into this level one, the general population, where unless you ask the question, you won't know the major problems they're facing. And if you can do that, and that's what we're currently working on, you will be able to intervene and prevent ones from becoming twos from becoming threes, where the intervention is much cheaper and the outcome much greater for the population as a whole. And that, to me, is one of the steps in linking the individual expertise we have as family docs with the health team in your clinic, with the health resources in the community, and ultimately population health. Thank you.
So thank you for sharing that, Art. I'd like to, well, first of all, before I go to my second question, my first question is, since you're familiar with the legislation, what got written into the Accountable Care Act, was that what was written in specifically for New Mexico or for your project, or was that more broadly something that others can apply for funding for?
It was national. What happened was they had this idea that, wait a minute, there's this idea of extension, and it's very popular in rural states. So, you know, senators all knew about this. And so the fact that you could tie something that was familiar with them in agriculture to a health problem, that is access to primary care and quality of primary care, was very appealing. So they asked us, because we were really the only state, the only other state that was piloting something like this was Oklahoma. So we worked with Oklahoma and put together that primary care extension program. We just wrote it, and they accepted it. Now, it was written in as a part of the plan, but there was no appropriation. If you remember, there was a battle that took place. So all of the innovations, all of the pilot projects didn't get funded, but ours had been assigned to the Agency for Healthcare Research and Quality. They were interested in this for a variety of reasons. And what they did is say, well, even though Congress didn't appropriate money for it, we're going to put $4 million into it. So four of our states actually got an allocation, and we put this together. We piloted and expanded extension, how we would apply to improving primary care, helping primary care with all of its helping their community health, and lots of things. Now, what then happened is it was very successful, and that was called the Impact Program. So then they put $112 million, which they got as an appropriation the following, that was 2 years later, into the large program to reduce cardiovascular risk in primary care practices. So now we got this a bigger national program with 30 different recipients, and now they're working on another one. So the idea has, and then we've written a lot of articles and all this, but it was never meant for us. It was, I mean, we'd like to get a piece of it, but it was written nationally as an approach that would bring health and agriculture together. And what was just terrific that's happened more recently, because there's not enough of us at all. No matter what whatever the calculation, there's not enough doctors, nurses, anything. Is the decision of the land grant universities and cooperative extension to move into health, not exclusively, but to really expand that. And we welcome them because there's so much great overlap, and they have a lot of expertise, and every community loves them. They're every place. And so we've even gotten grants and shared our grants with them because the outcome is much better.
And can you tell me about your HEROES program?
So the HEROES program is unique. It takes health extension. The focus is primarily on social determinants, but they don't work with individuals. They work at the community level in training, so that they, for example, when we send health science students, they either do the training themselves, they orient students or residents to their communities. They will work on, like one of them helped write a grant to get an FQHC in a very rural area. They've never had one. Another one, like in Hobbs, it has the largest percentage of African Americans. She's African American. She's the one who set up the whole design of getting residents and students from lab sciences, nursing, to go there with his free rooms. I mean, free room and board. Whoa! And communities embraced them. She set that up, and she's designed it. They gave a 12-year contract. They're just repeating. We're going to go for the next 12 years to continue this program. We have one in that Santa Rosa area. What she did was remarkable. She got the community to develop leadership training. So she worked with us as a hero locally in Santa Rosa. That's kind of the Eastern Plains ranching, and mostly Hispanic community. And she got our business college to plan training for leadership in that community so they could improve their economic development. She also she went to the senior sewing circles with elders. They knit all the masks that they flooded the businesses with. They didn't have enough PPE during the pandemic. So each of them works with their community. They were very active during the pandemic. Each of them burying themselves in figuring out ways to help communities, businesses, health systems. So anyway, they're almost all master's level trained. Almost always they've had a health background in some case, in some form. They could be public health educators. They were they could have been medical assistants, home health care. They had some background, but at a master's level, they make, they're into the $80,000, $90,000 range. All of them are given instructor status at the university. So they have a faculty title, letter of academic title. But the thing that's unique about it also is they're driven by their community priorities. We don't tell them what to do. And this is awkward for the health science center. Usually they say, well, can't they all do diabetes? No, the community, that's not the priority. And we actually did a comparison. This is the research interest of the university, and they tended to follow what NIH was funding. But that was not the level of violence, depression, and suicide, all the things that communities saw as a priority, or drug addiction. That was different. And so they pushed the university to meet those needs.
Can you tie together for us, how does all of this activity that you've talked about, how does it relate to getting more of the right kind of people applying, wanting to become physicians in your medical schools?
So we've learned that you can't start at college. You have to start at latest, maybe in middle school. And each of them works at education. So let me give you an example. So area health education centers is one of the big pipeline development programs. That's a program in our office. But there's only 3 offices of them. So we put it's like we deputize every health extension, every year, health extension agent as an AHEC agent. And every AHEC agent has to be trained as a hero so that we have something more robust all over the state. So that means not just putting on local, like we work with the local schools, not just talking about what careers could be, but identifying kids young who may want to be in any career, any health career, and tracking them. Because if you track them and go back, and especially when they're younger, work with their parents, that is by far the most successful way. Now, we know that for community health, the biggest impact will be just graduate from high school. That's a huge leap. Then from high school, can you then take the next leap into a junior college or a 4-year college? The next leap. At each step, the Health Science Center has a way of talking about health careers at each step, but we have to keep tracking them. It's out of that pool that we got that group I told you about, that quarter that were interested in becoming physicians, and they came in through this BAMD program. So you build, but it's you're not a failure if they don't become doctors. You're a success if they graduate from high school, so that you have all kinds of careers. The next thing we're doing now is our heroes are now working with high schools so that the students can be duly credited, that they graduate with a certificate as a community health worker, so that even in high school, they're doing community health work. And then when they graduate, they can become a full certified community health worker. Because if they, just imagine, if they apply to medical school, even when they come from a poor background with an education system that's shaky, but if they've had that background, especially in this environment where people are saying, what the hell are we having all these standardized tests for? Then they look a lot better. So we feel that every responsible, let's say, family medicine program should be investing in a pipeline way back, not just through college. That's great, but you're going to have to start earlier than that. And you have to look at community leaders, and whether they could be ministers, they could be your local doc and local health system, whatever it may be. So I think you have to mobilize the community in a very different way. As it turns out, this is popular because probably the most rapidly growing sector of our society is health. We're all getting old, right? Look at the number of pills I have to take every day, and I can't find the freaking primary care doctor. So that everyone is realizing this is the area of expansion, and there's a lot of money in the system compared to other systems. So when you can get kids excited about that, it helps them stay in school. They have a career plan, but you follow them along, and you want to guarantee that they can take the next step. And that means they're going to face all kinds of social problems and others, but you don't let them fail. That they may not go this way, but you'll help them go another way.
So these kinds of pathway programs that begin back in the middle school, they're a long-term investment.
Right.
And how long have you been kind of consciously doing this, and what kind of results are you seeing?
Right. So probably the best result is the BAMD program, because that was a result, not just of saying out of high school, we'll guarantee you admission to medical school if you pass, you have to pass through college. But in other words, you don't have to leave the state. That's very important. It's important also because we know that if you, let's say you're a Native American student and you're just the top of your class, you just are just a really great candidate for college, they will be picked up very quickly by Harvard, by Dartmouth, by Stanford, one of those schools. quickly, and you'll lose them. They'll never come back, or the number coming back are so few. If you can keep them in state, they will really stay and have a high likelihood of going back to their communities. Not all of them, but at least a third. I mean, that is really high. So it's worth the investment for a public school in particular, because they get the results. So it's hard for a public school to compete with some of the advertising of other schools, but they don't graduate with debt. I mean, schools are really inexpensive compared to others, and they get all kinds of scholarships and things. So it's, to me, by far the best way, but that doesn't happen unless you change the nature of the school deciding who do you want in the school. If you go through a traditional admissions process where the admissions officers are trying to clone themselves, you'll never get here. It won't happen. You have to populate the admissions process with people from the community. They could be docs, but it has to also be the ethnicity of that community. You know, if you have a lot of money, you can go abroad. You can work with Mother Teresa. But that's not what most people can afford. So you have to have someone who realizes that if you can fix tractors and you're the captain of your football team, that is leadership. That is a person who survived. But that won't come if you have someone, you know, from a big city who's looking for other kinds of, has the other values. And they're wonderful people. It's just that they don't have a lived experience.
So as we finish up here, any final recommendations for others who want to learn from your experience?
I think that family medicine doesn't exist in a vacuum. Some of the best and most important allies we have are in the communities. Sometimes we fight battles within the academic health center. Everyone, you know, we're very siloed and everyone protects their own turf. But family medicine has a real link to its communities. They have graduates who actually feel loyalty to the institution, which is enormously valuable to the institution. We can move beyond the traditional battles about taking very fixed, inflexible Medicare dollars for residencies and look at Medicare in a radically different way. Like there are other states doing this. We just passed a state legislature to look at the primary care spend rate. It's shockingly low, and it should be very, very high. So when a state looks at that and realizes the connection between adequate funding for primary care and the fact that it is almost the only way you can get improved health outcomes with better quality and lower cost, then they take notice, because it's the state putting huge dollars into Medicaid, into jails, and everything. So I think family medicine should be on the cutting edge of making those arguments. We don't exist in a vacuum. We learn from other states all over the place, and we just repackage them into Mexico and don't give credit to anyone else because we're as crazy as everyone. So I think creating learning communities across the country are really important. Up until recently, the feds were not the cutting edge of innovation. It had to come from the states, and so to learn from each other. Now, I think with the Biden administration, it's still changing, but they're still looking to innovations from state to state. And I think that's what we should be creating.
Thank you very much, Art. I appreciate you. I'm sorry that you can't be with us during the session that's upcoming. I understand you're seeing patients all day, so that takes a priority. But we've gotten your message recorded here, and we'll be able to share it with the group. And when it's all done, we will have all of the presentations shared. There's one that I think you'll be very interested in. A PhD by the name of Hannah Maxey has a statewide healthcare workforce database. And she's developed a process so that she, for the state of Indiana, knows where everybody's practicing, what kind of practitioners, PAs, nurse practitioners, dentists, etc. And it's all, I think it's the best in the country from what I've been able to tell. I suspect that may be very interesting to you, but we'll get the links from that to you. And again, thank you very much for joining with me today.
Great, thank you, Larry.